Hey, friends. Welcome to the podcast Studies in Counseling, where we're exploring some of the most engaging and absorbing questions in the field. We aim to delve deep into topics such as counseling theory, technique, and practice, as well as some current research in the field. Today, I'm really grateful to be with Dr. Kevin Doyle. Hey, Dr. Doyle, how are you today?
I'm good, Brian. How about you?
I'm great. Yeah, I've been really looking forward to this conversation. And kind of what we've been doing traditionally as our first question is this word engagement, thinking about this word engagement and reflecting with our guests on it. So I'm curious, when I use that term, what kind of comes up for you? Has there been anything that's been particularly engaging in your life recently, in your work or just in life in general?
Gosh, what a big question. I think that life is about engagement, and I think that one of the things that comes to mind for me is in my role at our school, we want to engage more with our alumni, and I think that's a key to relationships. And so we have 1,100 alumni. I'm at the Hazel and Betty Ford Graduate School, and we've only been around for 24 years, so a pretty new school. And one of the things that I say when I meet alumni is we want to stay involved with you. We want you to stay involved with our school. And I think engagement implies intentionality. You can wait for paths to cross. People say things like, I hope our paths cross in the future. Well, they may or may not, but you can influence that by reaching out to someone, just saying, "Hey, I was thinking about you," or "How are you doing?" And COVID has just affected so much of how we look at the world. People were not engaged in ways that we were before, and so I think we have to all take a step back now that we've moved into this virtual reality world, of being intentional about engaging with one another. Manufacturing reasons to just reach out to somebody and say, "How's it going?" That sort of thing. So anyway, kind of a rambling answer, but that's what comes to mind for me.
That's brilliant. Thanks, Dr. Doyle. So you're putting it in the context of your, hey, Dr. Doyle, could you do me a favor when I'm talking? Could you mute? I'm hearing just a little bit of an echo. Yeah. And this is fun because we get to engage our audience. They are in the process of this interesting virtual conversation we're having. But you're putting it in the context of your work engaging alumni at your graduate school. And this is so fascinating to me. It's one of those like little synchronicities I had. I'm currently a graduate student and I was having a conversation yesterday with one of my peers who's at a different developmental stage. They're outside of graduate school now and working in the field. They were talking about how much they miss school, like the time. It's such a blessing to be able to engage thoughtfully in conversations like this, and it's easy for that to decay. And so maybe that's like an emergent, cool property of this podcast is we can invite people into these kind of educational conversations and getting engaged in research. And okay, so we met um, through your work, some of your research work. And I'm curious, and it was in the we'll get into the specifics of it, but it was in the context of addiction. And you're currently working at the Hazelton Betty Ford Graduate School. What is it about this topic and field that you think is engaging you so much? So back then when you wrote the paper and then throughout your career. So what is it about this field?
Yeah. So for me, the word that comes to mind is transformational. And I personally happen to identify as someone who is not in recovery. I don't have, to my knowledge, a substance use disorder. When I started doing this work in the 1980s, much of the workforce was composed of people in recovery, and they bring a certain perspective, a certain passion. I heard these stories of recovery, and I was just, to use a clinical term, blown away, you know? And so it was just so inspirational to me to hear these transformational stories. And there was some part of me that I think said, I want to be part of that somehow. Isn't there a way that I, as a person who may not have this disease or disorder, can contribute? And of course, the one of the fallacies I think with all respect to people who are in recovery, which is just amazing. We don't have that standard for other mental health disorders or physical disorders. We don't have the expectation that you have to have had bipolar disorder to be an effective provider, or on the physical side that you have to have had a certain surgery or condition, to treat that. And so I do think the passion for working in the addiction or substance use disorder space often comes from personal experience, but not always. And so I think that's what contributed for me, is hearing these just really remarkable, turnaround stories, transformational stories of folks who were in the depths of despair and had arrests and health issues and family tragedies, who, by virtue of getting the help they needed, were able to overcome those things. That's just, it gives you chills, right? And so, and then as I moved later into my career, not so much doing the direct work anymore, but really being the one, I think we all kind of think, who's going to do this work, after we are no longer doing it? And to see students coming up who have that same passion, it gives you hope for the future. So that's sort of the gist of it for me.
Oh, interesting. Okay, so what really is gripping you and absorbing you through with the study, substance use disorder addiction, is transformation, stories of transformation, and you've reflected on, it's something we'll get into too, about lived experience and recovery, and very interesting connection about, like, yeah, we don't expect doctors treating XYZ syndrome to have that. I hadn't put that together. That's very thought provoking. And then also, I was noticing too, you're interested in education now, and there is such a transformative element of going through an education program, and that's another interesting connection, when we're learning to help others, and with whatever we're working on, but specifically in addiction as well. Yeah, fascinating. Okay, so this brings us to the work you did. The research that I read, substance abuse counselors in recovery, implications for the ethical issues of dual relationships. And yeah, I can see, based on some of the themes we talked about already, some we've already touched on them. But what do you remember about, like, creating this and the development of this work? I'm curious, like, when we're reflecting back, and this is coming out in the 90s. I think 1996. You can correct me if I'm wrong, but it's when it came out. But yeah, what do you remember about this work?
Yeah, great question, and thank you for phrasing it that way, because it was it was a while ago.
Yeah.
So this paper grew out of a course I was taking in my doctoral program called Writing for Publication, and I'm really grateful for having taken that course. Dr. Cortland Lee, who is a past president of the American Counseling Association, big name, was the professor, my advisor, and I think it can be pretty intimidating for newcomers in the field to think about writing for publication and getting published in the journal. And this journal, the Journal of Counseling Development, is the flagship journal of the counseling profession of the ACA. And I'm not sure I realized that at the time, but I had these thoughts, and research takes many forms and shapes. And this was not a quantitative research study. It wasn't a qualitative research study. It was a thought piece. And those are important parts of the professional literature as well. And I've tended to gravitate toward those, putting ideas out there, raising issues, making connections with, in this case, the ACA Code of Ethics, pointing things out that future researchers or professionals might build on. That's how good research is done. You look at what's out there, you do your literature review, and you say that certain authors have raised these issues, and we want to explore them further. And so, so what I remember is thinking that I hadn't seen much about these topics in the literature, and maybe I would try to make a contribution by pointing some of them out. And so back then, they were really paramount, because in the the 70s, 80s, 90s, the workforce was largely people in recovery who were, for the most part, doing great work. But I don't think at that time there was enough guidance provided around, here are some of the ethical minefields that you have to be aware of. If you're a person in recovery and you go to a 12-step meeting and you see one of your patients, there or one of your clients there? How do you navigate that? There wasn't much guidance for that. So I wanted to throw some of those things out. And, and of course, you could see a former patient or client there. Is it from 6 months ago? Is it from 5 years ago? Is that different? And of course, anyone can be a future patient or client, so you might be interacting with people that the following week might come in for treatment. So thinking about how to navigate those situations was really what was front of mind for me. And I wanted to kind of start the dialogue. And I've heard from people over the years who, and that article of all I haven't done a huge amount of publication, but of all the things I've published, that's the one that's been cited the most in future articles that people have drawn.
Yeah, and it's so interesting, Dr. Doyle, too, about so your process for this is, first of all, you're taking this course, which is interesting to hear about more of the context and the history of this. So this is pretty early in your research career, and you publish in the flagship journal of counseling. So it's an accomplishment, and it's coming out of just a lack of guidance at the time for folks in recovery, or just the field on navigating some of these ethical minefields, as you put it. And it's interesting. I think it's still making an impact, at least on me. I'm a person in recovery studying to be a counselor, and Pittsburgh is a decently sized city, but the recovery community is still pretty small. So this is an issue that was really thought provoking for me. Been to a few meetings around and how would I navigate that. So it was helpful personally. So I was really, really glad to read it, and glad we're trying to build on it. Okay, so I guess maybe talking about this other word I have, you touched on it a little bit, Dr. Doyle, but process, research process. Before we get into some of the specifics of the paper, like, what is it like for you to come up with maybe this particular idea, or just any idea? Like, what is it like what is your research process like? I guess is what I'm trying to ask.
Yeah, that's a great question. And I don't really think of myself as a researcher. So I'll
Okay.
answer from the perspective of a kind of a non-research guy, if you will. I think a couple things come to mind. One is just I I think about our profession, and I run into situations that um, I find interesting and want to know more about that. And so I think there's sort of an inquisitiveness, a curiosity, an intellectual curiosity, maybe is the phrase, that that is a good thing to have, and I think I have it, and leads you to want to explore, is there any guidance out there in our profession around this situation? So that's part of it. The second part that was not in place at the time that I wrote that particular piece, but has certainly been since that time, is that I have served on the licensing board in my home state of Virginia 4 terms, and then I was on the ethics committee for ACA. And one of the things that happens when you're in situations like that is you're asked to adjudicate complaints that are made against counselors. And you do that, but I think you also think, what went wrong? Why did this happen? What flaw is there in the system that people didn't realize that this activity could become problematic, and they would end up having action taken against their license, maybe lose their job. They might not even be able to work in our profession anymore for the more serious kinds of offenses. And so that causes you to drill down a little bit and think about, are there areas where maybe we've let people down by not adequately preparing them? Now, there's going to be a small percentage of people who violate ethical boundaries regardless. You can never, in my opinion, get 100%. And it's across professions, medicine, nursing, psychology, social work, counseling, whatever it is. There's always a small number of people who are so-called bad actors. But if we do as good a job as we can, hopefully we can minimize those folks down. And so in terms of my process, if you will, that's been informed by seeing the mistakes that people have made in the profession, and trying to, when I've taught ethics courses, which I did for many years, using real examples, not just theoretical. It really would bother me when students would say, "Oh, ethics is so boring." I'm like, that's the least boring topic of all the things we have, because you can look at real life scenarios of where things went wrong. And I tried to do my best to make it come alive by talking about those kinds of scenarios in class. And so that informs the process for me. Whether you call that a research process or not, I might call it a writing process. And that's what I've tried to bring to the work that I've done is looking at the real life issues and how we can do our best to prevent those kinds of problems in the profession.
This is fascinating. Your process. Thank you for articulating it like that, because these are my words, but it's like almost like a bottom up process, meaning you encounter things out in the world, specifically recently, based on your terms, working on ethics, these situations. Use the term like kind of inquisitive mind. You come across these situations and you're like, what happened here? And how did this go wrong? And like, what is out there to help navigate the situation? And if there's any gaps, like maybe we can take the responsibility for helping close them if we have the bandwidth and capacity. So just being open to kind of being surprised, I guess, and then seeing and just going with it and staying present and engaged, to go back to that word. Okay, interesting. And so I'm also glad that you have such an orientation towards ethics, because and you're one of the first guests on our show, because one of the interesting findings from our discourse analysis of the Journal of Counseling Development on Addiction was morality. We did a process of a sentiment analysis, looking at how just authors, how the topic of morality came across in these papers, in these research articles. And so I'm curious, it's a very broad, big question, but morality in the context of addiction, like what's kind of coming up for you on those two topics coming together?
Yeah, gosh, a couple of things. That's a great question as well. And certainly the history of addiction, we don't even use the term substance abuse anymore. That was a term that was in the title of that article. We say substance use disorders now. People with this disorder, this category of disorder, were seen as bad people, immoral, poor character, all of that. And so we've made progress in that area. The word stigma is used frequently. And so what has become important for me is to try to be an advocate for folks who have this disorder, particularly those in recovery, but even those who are active in their addiction, if you want to use that phrase, and point out the discrepancies between how we treat people with other disorders, chronic diseases, whether physical or mental health, and how we treat addicts and alcoholics, the terms that we use even, But for example, one thing that's become a point of passion for me have been restrictive laws that interfere with people in recovery from becoming contributing members of society, whether it be against people getting driver's licenses. In my home state, you could have action taken against your driver's license. It had nothing to do with it driving. I'm not talking about drunk driving offenses. I'm talking about things that people did. So instead of just getting, a jail time and probation and a fine, they also had their driver's license removed. Well, if you want somebody to become a productive member of society, you want them to work. And if they don't have transportation, that sets up a real unnecessary roadblock. People in recovery are such an important part of the workforce. But if you have any of the following convictions, which are true in a lot of states, you can never work again, or 5 years or 10 years, when you can show that their criminal history was a direct tie to their substance use disorder. In other words, once they received treatment and became a person in recovery, the criminal activity stopped. This is not someone who is placing people at risk. And these are all moral questions. They're all questions of how do we treat people. And there's a DEI component to this, and there's a social justice component. There's a socioeconomic component, that who's likely to be convicted of crimes, people without resources who may not have adequate legal representation. And so there's Michelle Alexander's book about, mass incarceration and all those things. How does this play out? And so I think that morality is a piece of it, and we have to challenge the status quo sometimes when the research leads us to know that substance use disorders are a legitimate disease or condition. Yes, people have to take responsibility for what occurred during the active time of that, but there shouldn't be lifelong bans against people who've done everything right, taken responsibility, have received treatment, and can now be contributing members of society. Why do we place barriers in the way of what all of us would really want? Um, so I think that that's that overlap between counseling ethics and the substance use disorder community that we're challenged uh, to uh, to attack that. And one of the things in the ACA Code of Ethics, and it's interesting because I've never seen a complaint against anyone for not doing this, but we are all expected to engage in advocacy. It's in the ACA Code. We're expected to do that, right? Now that's somewhat aspirational, right? It would be interesting if there was a complaint against you, Brian. Well, Brian violated the code because he is not an effective advocate. I don't know how to go very far. So that's why I say it's aspirational. But I think that call to be advocates for clients is really important. It's become important to me, and so that I don't know if that gets at the morality piece of what you were asking, but that's what comes to mind for me when I think about that.
Yeah, absolutely. I think it's a really interesting reframing is the word I want to use, because like this moral model, this is a big topic in addiction, substance use disorder, and we'll get into the name thing in a second because that's another finding of the discourse. But there's it's such a big topic: disease model, moral model. Like these topics are coming up, and moral model is led to, according to some, like stigma. Was a term you brought up, and like being very punitive to people in recovery and people coming, and this can create like a kind of self-fulfilling prophecy or a vicious loop. And then you're talking about how we as counselors could help intervene. There's a recovery advocacy movement that's very active in reducing stigma or trying and celebrating recovery, and we can be a part of that. And that could be a moral imperative for counselors and part of our aspirational code of ethics. So I really like the reframe of the morality is affirming morality and addiction, but applying it to our aspirational values as counselors. Okay, what about this thing? We could probably go on about this, but what about this thing with the name? That how we name? I'm using addiction just because I have a recovery background, and that's how we're talking about it. And I'll just talk a little more on this as a supplementary to thing to the Journal of Counseling Development. I looked at the hashtag We Do Recover, and addiction, of course, in that one, for people who don't know, this is people on Facebook or Instagram talking about their recovery. That's the term people are in recovery using. So, but in our field, it was so interesting. So we've got dependence, abuse, addiction does come up. Substance use disorder doesn't come up too much, but it's been later, so there's a historical context. But like, and it's even kind of a symptom of this conversation. We're calling it different things, and that adds to confusion, right? That's a difficult thing. What do you make of the? I'm calling the discourse like what's in a name in our research, but like, what do we call this phenomenon? Like, I mean, another thing I could ask is like, what is addiction? What is substance use disorder? Maybe there's a definition problem, but the name thing, like, I'll just throw that out. And like, what do you make of this in your career?
Yeah, I think it's a healthy discussion. We want to make sure that we don't get too distracted by this and keep our focus on, the really important things like access to treatment, for example. But it's all interrelated. And so substance abuse sounds like willful behavior to me, and I think to a lot of others. And so we've moved past that. However, change takes time. So SAMHSA, the leading federal agency, is still the Substance Abuse and Mental Health Services Administration. And IAAA, the National Institute on Alcohol Abuse and Alcoholism. That's still the name of that. So we maybe, and there have been some discussions around changing those names. So they're not entirely gone. I think addiction doesn't offend too many folks. I don't think that perpetuates stigma terribly, but substance use disorder is more consistent through using the DSM-5 language, for example, with how we classify other disorders, mood disorders or thought disorders. So SUD sort of thing reminds people of, STDs, or sort of, there's a consistency of language, I think, that is helpful. Feels more clinical, and that's kind of the point, is that we're trying to say this is a diagnosis, a disease or disorder, or whatever term you want to use there, that responds to treatment. We need to devote resources to treatment. There's a body of knowledge that exists to help us know how to treat people with these disorders. And there needs to be parity in coverage, which has been a big battle as well. And so framing it, a word that you used earlier, Brian, and framing this as the disorder that we know it to be, I think is helpful when we're trying to get the resources that are needed to address this condition. So again, it may not be the number one priority, but these are all interrelated things, and you run into stigma all the time. And one of my heroes in the profession is a psychiatrist named David Maylea, who's written a lot. He has a monthly newsletter called Tips and Topics, and he's been a trainer. He's at the end of his career now, just doing some consulting, and he's done a lot of speaking and training for counselors. And I wouldn't say that every psychiatrist is necessarily an expert around substance use disorder, but David Maylea is, and he was one of the first to really point this out. And the specific example he would use in his trainings would be, how many of you have ever used the term dirty urine? And we would all sheepishly raise our hands. He said, think about that. This is the profession saying dirty urine. And he would say, if you went into your doctor's office and your cholesterol was elevated, your primary care provider would not say you have dirty cholesterol. Your PCP would say the result of your cholesterol test is elevated. Let's talk about that. And he said, similarly, for substance use, if someone has a positive test, you say you have a positive test for marijuana. Let's talk about that. Let's look at your treatment plan. Let's look at your recovery. What's working, what's not. Let's adjust the treatment plan. That was one of those moments for me where the light bulb went on. I'm like, well, wait a minute. We need to treat this disorder just like we do other disorders. And so terminology is part of it. So I don't think I've ever used the term dirty urine since I heard him say that. It reminded me I can perpetuate stigma even as a professional in the field. So how we talk to our patients and clients, how we treat them, back in the old days, we used to say, when you're a newcomer, shut up and listen. Well, we don't say that to patients or clients. That's incredibly disrespectful. I used to say to people, here's your treatment plan. A treatment plan needs to be a conversation between patient and provider, or client and provider. Let's talk about what your goals are. What do you want to accomplish here? And that doesn't mean the client or the patient dictates treatment. It means it's a partnership, right? If I impose a treatment plan on someone, the likelihood the person's going to do that is much lower than if we have a conversation. Say, well, I hear you, but I think maybe, what about if we do it in this order? Maybe this priority would be better. Here's what the research tells us. Respect this person enough to listen to what they're saying and map out together. Let's attack this in this way, right? And so, again, kind of a long-winded answer, but terminology is wrapped throughout all of that, and a lot of times symbolizes what do we think about this person. And I think now it's in line, using the term SUD or substance use disorder is much more in line with other diagnoses and how we treat them. So there's a lot of work still to be done. And I don't think it's the end of the world if someone uses one of those terms, but I think it does reframe it for the providers and also for the patient or client or the individual with the disorder to hear it framed that way. So.
Yeah. Wow. First of all, thank you so much for that answer, because it's making me think of, circling back to the start of our conversation, the importance of kind of engagement and intentionality with how we're using our words is important. And especially with this one, because as you're talking, I was hearing a lot of care. I was parsing it as how much you care about this issue and care about people. And there's such, and I definitely have internalized this personally, but there's a harshness with addiction. There's like a harshness that can, it's almost like I want to use like a cultural complex or something that is just not there. It's not as present. It's easier for, I'm generalizing, but it seems so easy to tap into tenderness and care if someone has, cancer or something. It's so easy. It just is natural, but there's like almost like a block um, there, even personally, yourself and others too. And there's like this harshness. And I hadn't connected with being intentional and engaging with like, I'm going to choose to use substance use disorder. Actually could be a great gateway into tapping into more of that care. And it's also more fair too. There's careness and fair, which by the way are two of the moral foundations that we're looking at is care and fairness. And I was hearing both of them come out and I'm curious, would you agree with that kind of summarization or how did that land for you?
Yeah, absolutely. I think those things all do tap into it. So certainly I think you're on the right track with that, and I'd be 100% aligned with that. And of course, some of this too, in terms of language, depends on the setting. I, People in recovery, like if you go to an AA meeting, they might use the word drunk, and in an AA meeting, in the context of that, that could be perfectly acceptable in that form, but I would never use that, in a public setting, that's more of the sort of the familiarity that within the rooms of recovery, you can use terms like addict and alcoholic, for example, or drug, as a way of sort of a collective bonding. But in the professional setting, I think we can do better than that.
Awesome. Thank you, Dr. Doyle. Yeah, it makes a lot of sense. How a stigmatized population is talking about themselves is something to be negotiated in those contexts, but as professionals, we have a different context. And speaking of that context, another finding, a very interesting idea coming up in some of the research was how do we relate to a field to substance use disorder as a field? There's like questions about specialization, credentialing, etc. And I just noticed in this conversation, I was thinking about how I don't know how it is in Virginia, but in PA where I'm located, we split, and federally too, like mental health and substance use disorder are split funding wise. And so that's an interesting component in this as well. But as counselors, what do you make of this? Like specialized training, this kind of how do we relate to this as a field? Yeah, any thoughts on that?
Yeah, a couple thoughts on that. You know, I I think that over my time in the profession, we've recognized that anyone who's going to be working as a helping professional, anyone needs to have at least a working knowledge of substance use disorders. Even if your specialty is going to be working with children, recognizing the powerful impact that coming from a family where there's a substance use disorder present is going to impact young children. So it really has bothered me over the years when I've heard people say, "Well, I don't work with the substance use population," and my flippant response is, "Well, good luck avoiding that, because you can't. So you have to have a working knowledge." So KCREP has in its standards for accreditation that it's mandatory that you have training in your curriculum around substance use. My Even though I'm in Minnesota now, my home state of Virginia mandated a course in substance use. I think it says addiction actually. Um, but we've made progress in recognizing that this is such a pervasive issue in our country, at least, that you have to have some ability, even if you're not going to treat it, to recognize it and refer. And you can't do that without a knowledge base. Um, so I think that's important. I do think that, as you said, there are these, the separateness that is problematic. As I was coming up, the phrase was dual diagnosis, and there seemed to be a lot of energy directed toward, which was primary and which was secondary. And now we've moved much more to an integrated approach, which is way better. We use the term co-occurring disorders now. So you really try to look at this individual person and all of the different factors that influence this person's life. The crisis or the precipitating event could be, an overdose or a hospital admission for substance use, but you have to look at everything about this person. Are there mental health diagnoses? Are there mental health challenges? Is the person homeless? Is the person illiterate? You know, if we really look at this individual as a whole, we shouldn't have, you know, the substance use over here and the mental health over there and the educational background there and the socioeconomic problem there. This is a part of the whole person, and the treatment plan, how we approach this person should recognize all those different elements, and they should be treated in an integrated way. And one of the moments for me in my career when I had a private practice was I would occasionally call an individual's psychiatrist who was treating this person, let's say, for some sort of mental health disorder, introduce myself, let the person know that I got a release, of course, and say, here's what I'm working on with this person. I just want to make sure we're on the same page and we're working in a coordinated manner. And normally the first reaction was astonishment because nobody did that, you know. And no patient or client ever refused to grant the release because I would say, this will make me more effective in working with you if I establish a connection with your other treating provider. And often the psychiatrist would say things like, I'm really glad you're working with this person. Our sessions are brief. They're primarily for medication management. Thank you for reaching out to me. And we would collaborate, which is what we're supposed to do. And that's what the ACA code also says, is before initiating services, we reach out to another provider with permission to establish that collaborative care. And yet I don't think a lot of us do that. And so, you know, it shouldn't be these two different parts of this individual presentation. It's the whole person. Um, Having said that, a lot of people get labeled with mental health diagnoses when really what's happening is they're using substances and that was missed, you know, and so you don't want to rush into a diagnosis when you've never seen the baseline of what does this person look like when they're not in withdrawal or under the influence. So I like the idea of, you know, of being cautious and looking at 3 and 6 months into recovery, and now is the person's brain healing and are they returning to normal functioning? So acknowledging that, but there are certainly some people who clearly do have mental health disorders as well as a substance use disorder, and so that's the term co-occurring and should be treated in an integrated fashion to be most effective.
Yeah, yeah. Okay, so some of the keywords that are coming up, like being holistic, integrative, and in this powerful story of, hey, Dr. Doyle, could we do the mute? Thank you, thank you. But this concretizing that in that story of coordinating care and like both like the astonishment from the psychiatrist. I mean, I think that's one of a real gem from this interview is just that kind of technique, if I can call it that, of coordinating with other providers and seeing the whole person, and then that going to maybe. I mean, there's definitely I can see pros of specialization, of course, but then also it could be playing into this kind of cultural complex, as I was calling it, of kind of segmenting people in recovery, people with substance use disorder off, and like having that in a box that is separate from the other aspects of life. And so, yeah, holism, being holistic and integrative. Okay, I think this is an excellent segue into to another kind of discourse thread that was coming up, which was very fascinating to me, which was about I'm calling it getting better, and I put a question mark on that, like getting better. What do you make of this, like getting better in the context of substance use disorder? I'm trying not to do any leading questions here, but yeah, getting better, like what comes up for you based on your experience?
Yeah, thanks. That's a good question too. Well, it's about so much more than just abstinence. You know, that's the first thing is that's kind of hopefully a baseline, you know, of not using. But it's one of the beautiful things. Not that 12-step recovery is the only way that people recover, but if you look at the 12 steps started by AA back in the 1930s, what do you do with the wreckage? You know, that's my word, but maybe sometimes too strong. But all those things that happen during the active phase of using, and one of the things that people in 12-step programs do is figure out how to grow, become a better person, And there's even the process of going back and trying to make amends for some of the things that happened. I mean, we can't undo them. And sometimes they're pretty horrific, the things that happen when people were drinking or drugging, and and how do you heal from that? So
Mm.
getting better, I think, entails taking responsibility for those things, trying to make them right when you can, trying to move forward, addressing things like guilt and shame, that the things I did, gosh, when I was using, was I a bad person? Of course, no, we're still responsible for those things, but those are natural byproducts of having this particular disorder. And so, but what do you do with that? So engaging with professionals like counselors, to process some of those things. How do I move on from how I treated people, the relationships that have failed? You know, if I stole or committed crimes, what do you do about that? How do you move on and go forward in life? And so I think those are all at the crux of the getting better question. And then of course there's the physical side of this. The brain and the human body in general is just an amazing organism in terms of healing. You know, return to homeostasis, that fully functioning health. And when you look at, even like with cigarettes and all the different body organs that are affected by all these different substances, how the body is such an amazing way of returning to health over time. And abstinence obviously, really contributes to that. So there's the physical healing that is occurring, but then there's the mental health or sort of emotional side of it, with moving on from things that happen when people are using. And counselors are uniquely positioned, I think, to help people with that. And then finally, I do think that there's an element of recovery that connecting with others is just so powerful. And that's where the 12-step programs have really transformed, when you just think about the resources that are available to people that are free, and now partly because of the pandemic, but because of the internet, being able to connect with people around the world at any time of the day or night. You can hop on the internet and find a meeting where there are people who understand, and you can connect with folks. And realizing you're not alone, and that others have done. And if you think you've done something really bad, you usually find somebody who says, compared to what I did, that's nothing. You can move on from that. So you get that sense of hope. So that to me is the crux of the getting better part of it.
Wow, there was a lot of nuance in that response. I appreciate. Just want to double click on a couple aspects of it. First of all, this one about responsibility. So one thing I was very curious about you sharing is the facing some guilt and potentially shame as being fundamental or potentially fundamental to the healing process from addiction. And I've noticed that personally, and then also had resistance of letting go of some of that guilt. And I think responsibility is a really nice word. And I guess the guilt, there's a healthy desire to repair things. But then this guilt, this long-standing guilt or even shame is just not helpful. But this word of responsibility, I think, is really powerful. I really appreciated that. And then also, like you had mentioned at the beginning, of wanting to go maybe beyond abstinence when it comes to getting better. And two, there's this physical component. So we also have to reckon with chronic drug use or whatever, as it might not be morally bad. We can even be non-judgmental about use, but there are real physical effects, and there might potentially be an actual process of abstinence that is required to return to healthy physical functioning, which also I think brings a lot of nuance into the conversation. And then, community was the third part I heard. And also I hadn't really thought about this, but the scope of recovery fellowships, 12-step, smart recovery, whatever people want to do, it's really an impressive level of organization that people put in, and this kind of emergent thing that is a great resource for our society, really. So thanks for I don't know why someone who participates in it, it's almost unconscious to me how cool this is. After this meeting, after our interview, I could go find something at 10 a.m. Eastern. which is cool. I just have that security to know that that's possible. It's a really beautiful thing, and glad that maybe we can help counselors be aware of that resource that folks have. Okay, just a couple other things on this. So the things that came up were 12-step, which you covered, wellness, which I think you covered. Spirituality was one that came up. Those were like the three big things. I think things you brought forward with a bit more nuance were community and guilt, like this idea of like guilt. So yeah, I think it's interesting. It kind of confirms some of those findings. So appreciate that.
Yeah, there's such a recovery community that's out there in individual communities, and I hope that in-person meetings and meeting with a sponsor at a coffee shop, I hope all those things continue forever.
Yes.
You go to a coffee shop on a Saturday morning at 9 o'clock and you see two people engaged in deep conversation, and my brain goes to, that's a sponsor and a sponsee talking about the steps. And I hope that always continues. But we have to face the reality that there are people who are in recovery now who've had recovery for a couple of years who've never experienced the pre-pandemic environment, and their
Yes.
whole recovery has been through online connection. And that's the world. That's the world now. And for old timers like me, and maybe for you too, Brian, there's the traditional way of doing this, but there are a lot of other ways, multiple paths to recovery. SAMHSA, I think it was, wrote a report a number of years ago called "No Wrong Door to Treatment." It doesn't really matter how you get into this or exactly how you do it, but there are multiple pathways, and being respectful of that. But ultimately, doing this by yourself is really hard, and it's not what I would recommend for anybody. And when I've met clients over the years or patients over the years, and they say, I just don't want to do that AA thing, sometimes that's based on what they've seen in the movies or what they've heard. And so what if we agree that you'll try a couple of meetings, and then we'll come back and we'll talk about that in a counseling session. What did you like? What did you not like? Did it feel too religious for you, for example? That's one of the objections. And we talk about that, and I've often had good luck with that people have these preconceived notions, but then they feel that energy and that support, and sometimes that humor. 12-step meetings are not down in the dumps, woe is me. They are upbeat and positive for the most part, and people laugh at themselves and are so welcoming and friendly and gracious to the newcomer. And a lot of times people if they haven't experienced that, you want them to feel some of that stuff. And then if they say, I tried it, it's just not a good fit, then you do have a responsibility to move on and help this person find a different pathway. But that community is it doesn't exist for a lot of other diagnoses. There are things for people with mental health disorders that have sort of patterned themselves on this, but they've never taken off the way that this has for the substance use community.
Yes, thank you for that, Dr. Doyle. Okay, entering into kind of the final phase of our interview. Actually, I would like to establish a new norm for our podcast based on the inspiration that you're sharing. So this third phase is development. I like to think about development, and one of our intentions is to be historical and like kind of learn from the past and continue traditions forward and recognize them. Something I really appreciate that you've done is there's been at least twice that you've given a shout out to someone who helped you or you're learning from. There's a psychiatrist and then one of your teachers in the research publication. I'm wondering, could you resurface those names for us and then share anyone else who's made like an impact on you in your career as a counselor?
Gosh, yeah, I'd be happy to. And I hadn't thought about this before the interview, so I'm always hesitant to leave people out. But the two that I mentioned were Dr. Cortland Lee, who was my doctoral advisor and a past president of the American Counseling Association. So I certainly want to acknowledge him. And David May Lee, MEE-LEE, is the psychiatrist whose newsletter is Tips and Topics that anyone can subscribe to. That's free and comes out once a month. So those were the two I mentioned. And gosh, I'll probably not add additional names other than to say I'm so grateful for all the people who have helped encourage and mentor me over the years. There have been so many of them. And I would challenge all of us. I know folks who say things like, well, I'm not sure I want to be a supervisor. I don't want to take on that responsibility. I'm not sure I want to take on a counseling intern in my practice or at my site. I'm not sure I want to be a sponsor. And my challenge is there were people who did those things for us. Each of us benefited from mentors, supervisors, um, and I think we have a responsibility, to the people who will follow us to at least consider that. Maybe not today, but if it weren't for those people who helped us, we wouldn't have gotten to where we got in our careers. And so I think we all have an obligation, and I don't use that word lightly, but to help those who are following us. And so that's really important to me. And the phrase I sometimes use is "Don't big time me." We all have to keep that humility and be willing to help others, and that's a really important thing for me. So thanks for letting me mention those names, Brian. And I'll
Yeah.
just say they're too numerous to mention all of them, but I've really benefited from so many folks.
Yes, absolutely. Absolutely. Thanks for taking the time to reflect on those and offer us those resources. It's such a nice gesture to recognize people. Yeah, it feels good for me to do that as well. Okay, final question. You've been very generous with your time, and this is on the development thing. So reflecting back on your career as a counselor, like now we're here in 2023, actually on the first day of spring, which is nice. We're reflecting back on your development. Like, what kind of comes up for you? What do you notice about how things have developed for you?
Yeah, I think I would harken back to my previous answer is that people believed in me and encouraged me. Um, I certainly have benefited from a lot of privilege in my life, a white male from a stable family with financial resources. And so recognizing that, we need to be more diverse, we need to be more equity minded, we need to be more inclusive. The DEI phrase, the acronym is really important these days. And so to give some grace to people who may not have had the advantages of privilege that some of us have had and find pathways for them and be intentional about that, to recognize that not everyone has that same privilege and how can we dismantle systemic barriers. And so the criminal background, for example, is a systemic barrier that I think some people face. And like voting rights, for example, why do we remove people's ability to vote because they were convicted of a crime? What is that about? So really looking with a new eye on barriers and inclusivity, I think is really important. And being appreciative and grateful for the opportunities that we've had, but trying to be intentional about making sure that as many people who might want to do this work. And then as far as substance use goes, there are a lot of folks who still are hesitant to wade into this part of counseling. And I would really encourage people. Yes, it's challenging, and yes, it's difficult, but it's extraordinarily rewarding. I'm very active on LinkedIn, for example, and I will get people jump in and say, you may not remember me, but I have 4 years in recovery now, and I appreciate the things you're posting. And it's so inspirational to hear about folks who are able to overcome this disease and disorder and get into recovery. And so those are some thoughts that kind of keep me going too.
Thank you for that, Dr. Doyle. Yeah, the gratitude and the DEI component, and staying present with those as things are developing further in our field and in your life. I'm curious, I didn't ask you about this beforehand, but if folks who are watching this, they're interested in kind of learning more about you or any of the topics you discuss, we will definitely put a link to the specific article we were mentioning in the description where you find this. But are there any ways the audience can support you and take a look at some of the interests that you're working on?
Sure, absolutely. I would say the two would be primary. So my role is the president of the Hazel and Betty Ford Graduate School of Addiction Studies. We have addiction counseling programs both in person and online. And so our website is hazelandbettyford.edu. And you can learn more about our school, and I have a profile on there and different things. And so certainly love people to check that out. And then I am pretty active on LinkedIn these days, and I post a lot of thought pieces about addiction and recovery and treatment education. And I love engaging with people on there. It's a professional platform that doesn't have some of the baggage of Twitter and some of the other ones. I'm finding a lot of good connecting happening through that particular platform. So you can find me pretty easily, I think, by doing a quick search on LinkedIn.
Fabulous. We'll check out the website and also find you on LinkedIn. So, Dr. Doyle, I'm just really grateful for the time we got to spend together, and we'll see everyone on the next show.
That
Thanks.
sounds, Ryan, thanks for reaching out. I enjoyed being here.
Absolutely. Have a good one, everyone.